Hi, my name is Seth Baum. I'm a preventive cardiologist and clinical lipidologist, the chief scientific officer for Flourish Research, and a past president of the American Society for Preventive Cardiology. And I'm joined today by Dr. Jay Shubrook, who's an expert in diabetes and NASH and prevention. And we're going to be discussing NASH today. He and I had a very long conversation about a year ago, I would say, where we discussed NASH and what was currently relevant at the time and therapeutics in clinical development. And we also discussed more recently guidelines that were going to be coming out. And Dr. Shubrook was very involved in that, and now will lead our discussion today on NASH, its current state, and in terms of our management of NASH, our identification of NASH, our approach to NASH. We'll discuss cases, and we'll also discuss some therapeutics in development. So, Dr. Shubrook.
Yeah, thank you so much. I'm so glad to be here again. I'm happy to see you. And I do think this is an exciting time to say that we've got some direction and some guidance as it relates to identifying people who are at risk for advanced disease as it relates to NASH. We got some guidance in terms of what's the evaluation, and then really some guidance, at least early on, about treatment modalities. And these have been published in multiple journals. And so I do want to highlight that the overall guidelines were published at the same time in gastroenterology, diabetes care, metabolism, and obesity, and we'll give you those references. But even more useful is the clinical care pathway that was published in gastroenterology. And the pathway is important because what it does is it gives us a roadmap to work from. We're all very busy, right? We all have patients we're seeing, and we're trying to make sure that we have effective ways to identify people for prevention. And you know, just like our other cardiometabolic conditions, NASH is all about prevention. So I'm going to just highlight a couple of different figures here, and Seth, I'd love your feedback along the way as we go through this. But this is the working document, and it's meant to be utilized in the busy outpatient and inpatient setting. I will say that if you go to nash.gastro.org. It does have a good website with an app that actually has the ability to calculate all this and work through the pathway, all the references, and again, also patient educational materials, as well as podcasts. So let's kind of jump right in. So on the clinical pathway, the first and most important thing is we have to have a mechanism to screen for advanced fibrosis. Now, of course, we know that non-alcoholic fatty liver disease and NASH is a cardiometabolic condition. And so running along the background, we're always thinking, how does this relate to excessive cardiovascular risk? And how do we mitigate that? But in terms of the liver, we have to have a way to screen, because we know that we already have pathways for looking for other cardiometabolic conditions. So all team members should be aware of the way that we screen for NASH. And there are really three ways that you might access or start to look at screening. First of all, any patient based on these guidelines with type 2 diabetes should have screening for NASH. Any patient who's got metabolic disease with 2 or more risk factors should be screened for NASH. So that's the advice. But we find lots of patients through other testing. So if you happen to have a patient who has elevated transaminases, there is a pathway for which we want to make sure it's not other conditions. And if it's not, put them in the NASH pathway. As well as if you happen to have a person who's had imaging that shows steatosis on the liver, that's also the time probably to screen them for NASH. Now, the reason why that is treated separately is that we know that transaminases are not sensitive enough to really pick up lots of people with NASH, and there's many causes. And we know that steatosis doesn't tell us about the risk for fibrosis. So while those tests are pathways to get into screening, they're not the recommended initial screening tools. So Seth, I'd like to kind of hear your thoughts. You know, what in terms of thinking about these are the people we should be screening. Does this sound like a lot? Is this kind of something you would think that makes sense?
Yeah, so first of all, I think it's great that we now have a pathway to consider, and now this should become top of mind, because if we don't think about this, we're not going to identify these people, and if we don't identify them, they're not going to get the right treatment. It's kind of a common theme in medicine. We went through this with familial hypercholesterolemia several years ago, having to make that top of mind. This now needs to be top of mind as well, and yes, we are going to screen a lot of people. If you look at those three buckets, and so the phenotype of a NASH patient, the phenotype is somebody with diabetes or metabolic risk factors, such as obesity, high triglyceride, hypertension. So, how many of these people are there? Well, 2/3 of America are overweight or obese right now. Many people have diabetes, and that number continues to increase. And the obesity and diabetes epidemic are really what are leading to our reversal of mortality trends in the United States, where we're starting to lose ground. So we will be screening a ton of people with this new paradigm, but we'll be appropriately screening a ton of people so that we can mitigate some very significant downstream risks.
Yeah. And I do want to highlight that while that may seem overwhelming initially, I really do think this pathway is going to reduce referrals to gastroenterologists for liver biopsies and for advanced treatment, because it's really going to be able to help filter out the high risk people from the lower risk. So if you do that screening, and that screening should be done.
But I just want to add to that, since you are a primary care clinician, it does put more burden on the primary care clinicians, but it puts a burden that is, for lack of a better way to express it, a good burden, because you'll have the ability to identify people at great risk and as you say, limit the referrals downstream to the specialists.
Yeah, absolutely. And if it's simple, everyone with type 2 diabetes, it becomes part of my annual assessment.
Right.
So now I can automize that and not have to be thinking, should this person be screened? So the next step, I think is really important. You don't need a lot of testing. You need a CBC, and you need liver function tests, and you need the person's age. If you have those things, you can calculate a FIB-4. And a FIB-4, you'll have it on MedCalc. It's certainly on the app. This is something that would allow you to do the early assessment for your patient. And based upon your FIB-4 score, which again are labs we typically have in primary care, you could assess them to be low risk for advancing the fibrosis, intermediate risk, or high risk. And so, you have the FIB-4 scores listed there, less than 1.3. They're probably at low risk for a liver-related complication. That doesn't mean they're not at cardiovascular risk. That indeterminate risk is always the hardest one, because it's in the middle range, and you really have to take a number of factors in, and you might have to do a second test. Those with the high risk, a FIB-4 greater than 2.67, they're at very high risk for fibrosis and cirrhosis. They go directly to the hepatologist. So one, they can have the proper assessment, and two, they could get advanced treatments, because there are many treatments coming. And the hope here is, by doing this, it allows you to do the referrals to where the hepatologist can help the most, allows you to do that second test when we're not clear if the FIB score tells us enough, and allows us to focus on just cardiovascular risk focus if the FIB-4 score is low. Because we know that weight reduction, improvement in cardiometabolic conditions are going to help not only their overall mortality, but it's also going to help their liver-focused risk. Have you calculated a FIB-4 before, Seth?
Yes, I have. I will tell you, though, being in clinical research, I don't typically do it, because I rely on other factors. We have a couple of FibroScans here, and we skip the FIB-4, go directly to FibroScan, and then go into clinical studies or not. As I'm listening to you, I'm thinking, wow, this is really great that we have a pathway like this. I'm also thinking that we always have to keep in mind that our pathways and guidelines are just guidelines, and they're right, and they're population based, and they're structured to take care of large groups of people. and that there are always going to be outliers. And we always have to remember that we as clinicians are the ones who make the ultimate decisions with our patients about how to proceed. And if we think that something is not, because nothing's perfect here, if we think something is not completely right, we may go forward, even if the pathway would indicate that you don't go forward in the pathway.
Of course, you never wanted to replace clinical decision making. If there's a high index of suspicion, you follow that, right? That's what makes medicine the art it is.
Yeah.
So, and I love that you mentioned FibroScan, because, you know, a lot of people in primary care would then go to an ultrasound as the next step. And we really don't recommend an ultrasound as the next step because it doesn't tell us anything about the risk for fibrosis or inflammation. It just tells us about fat. So if you have a person that you think is at higher risk, or they meet the indeterminate or the high risk score, you should do a second test. That second test is a liver stiffness measurement. And at least at the time of the writing in 2021, we had recommended a FibroScan, because a FibroScan is, again, a non-invasive tool that is ultrasound based, that allows you not only to look at the liver, but then to get assessment of stiffness. And then you can see, again, 3 levels of stiffness, puts you at low risk, indeterminate risk, and high risk. And again, low risk people probably could be managed in that outpatient setting unless you have some other suspicion. Indeterminate risk, you're probably going to ask for some help. At least I would be in primary care. And the high risk definitely needs to go to a hepatologist. And again, the goal here is then to be able to give enough information to the hepatologist or gastroenterologist to be able to have an actionable plan, and not necessarily subject people to liver biopsies that may not need it. And so you had mentioned you have a FibroScan. Is this easy to do? Is this something that, you know, I think is easy to implement? Because we don't have them available everywhere.
Yeah, and we have them because this is a clinical research site, but it is easy to do. All of the coordinators are trained to do FibroScan, and it's not a complex training, and I think it's unfortunately it's a costly machine, so that's a barrier. But I think it will become more prevalent, more available as time goes on. It is already. I wanted to say that I really like the fact that in both your indeterminate risk and your high risk categories, you are suggesting referral to hepatologist, although obviously in the high risk even more so, but I think that's great, because if you have a KPA of 8 to 12, and that's in the indeterminate, that's not a low risk position at all. And that is a patient, given the right phenotype, who very likely does have some degree of fibrosis, maybe F1, may not be F2 or F3, but F1 is not a great thing. And there is a frequent progression from F1 to 2 to 3 to even cirrhosis over a lifetime. So it's great that you're highlighting that. This is a really nice pathway.
Yeah, we've found it to be useful. And I would say that one thing that has been updated even since 2021 is that one of the other tools to use to assess risk, which is the ELF, which is really a biochemical or inflammatory blood test, also has become available in the US. And it could be an alternative or a supplement to the FibroScan. And so I think, again, depending upon what tools you have available, if you're in the primary care space and you don't have either, maybe you're going to refer more often to gastroenterology or hepatology. But if you have the ability to order a FibroScan or an ELF blood test, that would really help you to triage that patient just a little bit more. And I do think that this will continue to evolve.
I think that's great that ELF is available. And just to reiterate, so ELF and FIB4 are both often part of these clinical studies, but always, I would say, pretty much always, a FibroScan is part. So some portion of inflammatory marker or other markers are used to gain more information and to really try to determine whether or not they can replace a FibroScan, let's say down the road.
Right.
Right now, they aren't. So I'm going to just push and say, when in doubt, get a FibroScan.
Sure.
Because it does have, I think, enhanced value.
Yeah. And again, non-invasive and it's
Right.
affordable when covered, of course.
Yeah, right.
Yeah. And then finally, I want to just highlight the treatment. And again, I think the treatment is also staged into low risk, indeterminate risk, and high risk. And no matter who the clinician is who's treating this patient, when you're looking at treating the patient, all patients need to have a cardiovascular assessment and need to really work on reducing cardiovascular risk. So that doesn't matter where they are on that spectrum. We're working on weight loss. We're working on blood pressure control. We're working on reducing lipids. And again, I would highlight, unless they have really advanced disease, you're going to continue to use statins. This is not the population. You're going to stop using statins because of a slightly elevated transaminases. So lifestyle and cardiovascular risk reduction is universal across the board. Now, when you go beyond that, I would say for low, intermediate, or high risk, I really want to make it even simpler than what we have on our slide here. Weight loss by any mechanism is the most important thing we can do. So if it's working through a structured lifestyle program, great. If you're using medications, fine. If you're using metabolic surgery, these things all work, but it has to be significant weight loss. And it's not, 50% weight loss, 10% weight loss has been enough to show that you change the trajectory of fatty liver disease. And so we really need to make sure that we make that the focus of the priority. And so again, for low risk people, that can be done at any of the healthcare professionals' office, focusing on weight loss, doing cardiovascular risk reduction, and standard of care for diabetes if they have it. If they have indeterminate or high risk, we're probably going to add a focused therapy that has benefit for maybe diabetes and has been shown to be beneficial in slowing the progression or changing the progression of NASH. And so, for example, we know that in type 2 diabetes, pioglitazone has evidence to show that it reduces the progression. So I might use targeted therapy of pioglitazone or a GLP-1 receptor agonist, two of which now have pretty good data showing that it slows the progression of NASH. And so I'm doing that for the extra glycemic indication of not only helping diabetes, but also helping the progression of NAFLD to going to NASH. And then certainly, as we see more targeted therapies for our patients with NAFLD and NASH, they're probably going to be offered in the specialty centers within the hepatologists. And so early referral for those moderate to high risk patients, give them access to these trials that you just mentioned, Seth, and let them have opportunities to have new treatments that become available that may be years away from being used more broadly.
Yeah, I think that's great. So with regard to the trials, there are over 50 drugs in development, tons of clinical trials ongoing for NASH. And I do think referral for those studies is a great idea. With regard to treating the patients in clinic so PIO, has the good data. It's important to emphasize it's not FDA indicated, right, for the management of NASH. So, but that doesn't mean we can't do it. We do that all day long. We prescribe off-label, but it's just important to note that just like vitamin E is not indicated, it has its place here. PIO has some potential downsides, with regard to bone loss and maybe bladder cancer. I'm not sure how, you would know much better than I what the current statistics are with that. But you also mentioned the GLP-1 receptor agonist, and given all that we've learned recently with regard to obesity and the GLP class, and since obesity is, foundational with regard to NASH, to me, it would make sense. And given the fact that you require a 10% or greater weight loss in order to get the greatest benefit, i.e. the reduction of fibrosis here, and fibrosis is what predicts the really bad consequences, which are cardiovascular death, cirrhosis, hepatocellular carcinoma, et cetera. It may be best to lead with the GLP-1 class. And I'd like to know your thoughts on that at this point, not at the time of the writing, but at this point.
Yeah, absolutely. Because again, I think that at least in the outpatient setting, weight loss is the focus of therapy. the GLP-1 is going to be the best option there for the things we
Mm.
have available today. And you're getting cardiovascular, you're getting potentially renal benefit. There's other potential benefits coming for GLP-1, and you've got the benefit for NASH. And so I think because of that kind of accumulation of all these benefits, and really a good safety record, we would go to them often first. The one caveat would be if a person has very high triglycerides, it's possible that we might use pioglitazone first to lower the triglycerides so that we show just a little bit lower risk of at least the concern about pancreatitis for those people that have a high risk already and get put on a GLP-1. Not that GLP-1s cause pancreatitis. But that would be the one caveat is in the very high triglyceride, because you get about a 40% reduction in triglycerides with pioglitazone.
That's interesting. That's a very interesting point.
Yeah. So I have a couple cases I thought maybe we could talk about and love to hear your thoughts.
Okay.
So the first case is a 58-year-old female. She's got polycystic ovarian syndrome, and she comes in complaining about unintentional weight gain. She's tried a number of lifestyle things and efforts and really hasn't seen benefit. She is, as I mentioned, 58, but she had 2 successful pregnancies. Largest one was about 8 pounds. And she's not taking any medication. She doesn't have any allergies. But she asked the question that I hear all the time: well, could this be my thyroid? Is that why I'm gaining weight? And of course, it could be her thyroid, but it could also be a lot of other things. She does have truncal obesity in her exam. She has no evidence of thyroid disease. And just to kind of move things forward, we did screen her thyroid, and her thyroid was normal. But we do look at the other kind of lab parameters, and she's got what we would call diabetic dyslipidemia. She's got a total cholesterol of 236. She's got a low HDL of 32. Her triglycerides are 264. And sure enough, she's got, looks like pre-diabetes and slight elevation in her transaminases with an AST of 42 and an ALT of 48. And her A1C is 5.8. So now, while she was worried about weight gain, now we're worried about a whole another set of things. So you see this patient, right? And what's your approach to her?
Yeah. So when we see a patient like this, we say this is a high risk patient, right? Oh. So she's obese. She has dyslipidemia that's very worrisome. If we were to measure her ApoB, it would be very, very high. Her triglycerides are up, her HDL is down. Low HDL, although not causal for cardiovascular disease, does predict premature cardiovascular disease. So that's important. Her glucose is fasting glucose is high. It's not in diabetes range, but it sure is getting close. Her liver tests are elevated. So there are a number of things I think about. I would say the first thought is she needs to lose weight, because if she loses weight, a lot of this stuff is corrected. The triglycerides will be improved after weight loss. During weight loss, HDL can fall, but ultimately it will rise. Again, that's not going to impact her risk of cardiovascular disease, but you should note that it'll happen. Her liver tests will probably fall, her fasting blood sugar will fall, but she's still, even though we know we can do all of that with weight loss, we still have to intervene right now and assess her for NASH, because this is the phenotype for NASH. This is a person, as I stated earlier, who has central obesity, who has triglycerides that are elevated, who has a low HDL, who has elevated liver tests, who has elevated fasting blood sugar, insulin resistant. So this is the person who has NASH. So we need to move forward with that as well. Ultimately, she will require lipid-lowering therapy as well. So that's what I'm thinking right now.
Yeah, and I love that, because that's exactly what we want the listeners to kind of think about. Is yes, you can act now on those cardiovascular risks, but in addition to that, because she's got these known risk factors for NASH, take the step to start to engage that pathway as well. And so if we walk through that, she's got at least 2 of those cardiometabolic risks and metabolic risk factors. So she's someone we should be screening. We did her FIB-4 score, and sure enough, it was 1.41. So that kind of puts her in that indeterminate risk. which to your point, and I love how you say that, that's not low risk.
Mm.
So, we can look at the absence of other liver diseases. She's not a drinker. She doesn't have hemochromatosis. She doesn't have Wilson's disease. So we check all those other things. And because she's in that indeterminate risk, we get a fiber scan. And our fiber scan is greater than 12.
Mm.
So this is, again, sure enough, this test has now shown us that this person is indeed not low risk and really needs to move forward to hepatologist. Now, that doesn't change any of the things that we're doing, right? We're still going to work on weight loss. We're still going to work on cardiovascular risk reduction. We've got to normalize our glucose, normalize our lipids. But this is a person who's going to benefit from also early intervention with the gastroenterologist. So that, one, if there's a liver biopsy needed to be done, it can be done. Or two, if there's directed therapy for the liver, it can be reinforcing to all the other things we're doing. Are you in agreement with that?
I think yes, I absolutely agree. I think it's also important to note her liver tests were elevated. She needs lipid-lowering therapy. And many people would say, oh, I don't want to do it. I'm worried about the liver. We don't have to be. And that's been very well documented. This is a person who should be on lipid-lowering therapy, including statins. And we can follow liver tests, and that would be a good thing to do, but not to worry about adversely impacting the liver. If anything, we might clear things up a bit. So I would just mention that as well.
Yeah, I love that. And again, in the primary care setting, absolutely, you should be comfortable using the statin that makes sense for that person's cardiovascular risk, because you've already ruled out those other conditions. And again, you're focusing not just on the liver outcomes, you're focusing on the thing that kills most people with fatty liver, which is cardiovascular disease. Mm-hmm. And so you need to do those treatments. When I'm looking at diabetes-specific therapies for that patient, I might choose things that are less likely to be hepatotoxic initially, but I'm not going to do things that are going to get in the way of, so for example, we mentioned a GLP-1 earlier. I have no concerns about using a GLP-1 in this person, given the current lab setting. So it might be things like metformin. It might be things that sometimes can take a little bump initially when you use them, but don't let those mild transaminase elevations get in the way of your good treatment, standard of care. So good. I got another case. You want one more?
Yes, please.
Okay. So this is a 40-year-old patient, also female. She has known type 2 diabetes. So she's got a history of type 2 diabetes, hypertension, dyslipidemia. We call that the diabetes triad. She's on metformin 1,000 twice a day. She's on a high-intensity statin of atorvastatin 40 milligrams daily. And she's on losartan HCT 100/25. So at least for many of our patients, those are three things that we kind of expect them to be on, right? Foundational therapy for diabetes, a statin, and a RAS agent. No allergies, no tobacco, no other medication. She does have truncal obesity with a BMI of 32. And sure enough, I think that when we look at her, she's someone that we probably should be screening also for fatty liver disease and NASH. So sure enough, when we look at her lab, she's got the same kind of diabetic dyslipidemia, 236 total cholesterol, trigs in the mid 200s. And her AST is 68 and her ALT is 48. She does have platelets that are 350 and her A1C is 6.8. So you might think that her glucose is fine, but her cardiovascular risk is not fine. And if we want to now engage in scoring her for her FIB-4 score, her FIB-4 score actually might be relatively low. And in this case, it was 0.96. What do you think about that?
Yeah, so this is, so I have a problem with this because the FIB-4 is going to be low because she's so young. So just based on the equation for FIB-4, she's young and her platelet count is high. So those two things are going to make her FIB-4 score low. And to me, when I look at her, she has NASH. I mean, this is the classic NASH patient, established diabetic, obese, dyslipidemia, liver tests that are very high, AST higher than ALT. I mean, this is like classic NASH. So I would not stop here. I would do a fiber scan on her. So that would be my approach.
Yeah, and I love that. And I do think it's important, as you mentioned earlier, that these guidances are just a pathway for you, but you don't let it get in the way of your decision making, the patient in front of you. And this pathway is really to help you to identify those people who are high risk for fibrosis and cirrhosis. I would actually say, if you ruled out the other liver conditions, of course she has NASH, but NASH has a number of stages. And if we keep going without interaction or intervention, she is going to advance to a higher FIB4 score if we do nothing. And if we really want to be sure, going to the FibroScan is going to let us know, can we really feel comfortable staying with standard of care for her comorbid conditions, or do we need to do more right away? And this patient doesn't have a FibroScan, so I can't tell you what it would be, but certainly, when you see this and you're looking at it regularly, don't let your suspicions or the guidelines stop you from moving forward, because again, this is a young person with a lot of years to protect.
Yes, agreed.
So,
good case.
So yeah, so I think this is what I hope that the listeners take from this is there is some guidance now for what I think is a very common condition. It is probably a really exciting area because we're going to see new therapies that are going to be available, but the patients won't get these therapies if we don't identify the condition. So we really have to say, one, recognize that this is part of the cardiovascular milieu, but two, we can actually do things that can help reduce the most common cause of cirrhosis in the United States, which is now, it's overtaken hepatitis C. So absolutely, we want to make sure that we're, one, doing the best we can for the number one cause of death, cardiovascular disease, but then two, preventing these unnecessary advances in liver disease. And again, we're a team, right? So, they might see the cardiologist, they might see the primary care clinician, they might end up seeing someone in the ER, but we all need to have a high index of suspicion and not become numb, as we mentioned earlier, to slightly elevated transaminases and truncal obesity. Is it 90% of the population's overweight or obese now? We need to make sure that we're taking a population approach as well.
Yeah. That was great, Jay. I want to thank you for leading that discussion. It was excellent. The cases are great. And I think you provided a wealth of information and insight for me and for the audience. So thank you.
Always a pleasure. Enjoy working with you.
I enjoyed it as well.